This is another case of uterine mass evaluation. Here we see conventional uterine fibroids. So the patient has uterine fibroids, it's characterization. And the area that caught my attention was this here. This it's got kind of these T2 cystic changes, maybe like a focal adenomyoma. I don't know. It looks very mass-like though, and kind of like a uterine fibroid rather than, that central mass from adenomyosis. For sure, it could still be adenomyosis, but when we look at this, we go through that consensus statement that Nicole Hindman and team wrote, and we reviewed already several cases. And I have some things, additional information and kind of knowledge to shed after this case, or as part of this case discussion. So there's the mass here, right? It's uterine subserosal, and so it's T2 intermediate. So it's enhancing. All of this is enhancing. Okay. So then the workflow tells us to look at the high B value, ADC, or a high B value and then ADC. So this is a high B value here. And here it is. So there's our mass here, right? It's pretty bright and it has to be brighter than the endometrium. And this is the endometrium here. So I would say some of the areas are brighter than the endometrium. Okay. So then if it's brighter than the endometrium, then you go on to the ADC. So ADC is here. And some of these areas I got it to be pretty low. Below, I think, was it 950 or 900 cutoff?
900, yeah.
Yeah, 900, I think, right? Like some of these areas I got it down to like 8 something right there. Okay. So and I can pause and show the ROI to prove it to you. But what do you guys think in the meantime?
I think it's a fibroid.
Yes, tell me why.
It's very well circumscribed and it's very homogeneously enhancing. And to me, that a leiomyosarcoma would not be homogeneously enhancing like that. So, and fibroids can have low areas. So it's like actually just looking at the enhancement, I don't even know if I would have gone to the algorithm to say like, because that I'm suspicious for an LMS.
Because of the enhancement?
It's so homogeneous. Like I feel like
Here.
LMSs would not be yeah, but also on the enhancement.
Oh, in
But
the enhancement,
like
yes,
even
yeah.
this T2 signal is pretty homogeneous. And fibroids can have these cystic spaces, but like, yeah, look how homogeneous that is.
Yes. And so okay, there's a paper that Angela, who's also Nicole's partner, they're all at NYU. So this was a paper that was published in JMRI, and I think it's a really enlightening paper. Um, uh, so the the and some of the things that you mentioned is mentioned here, right? Like how do you like separate it? Because to me, that consensus statement created more issues than like help me solve problems. And I realize it's because I'm not really like taking that workflow like in its purest sense is not the best way to approach it. And there's other features that I think are mentioned in this paper that I think can be more helpful. So first of all, so yes, ADC is really like combination of T2 and ADC are important. So they mentioned like if you separate the sarcomas, LMS, as well as non-LMS sarcomas, there is a separation between fibroids and sarcomas. So this was a retrospective study with surgical pathology, and then they looked at various features that separated benign from malignant masses, uterine masses. And they use a Likert scale. So they did a binary. So anything that was like this or that versus less likely or higher, they grouped into 2 categories. And they did a box plot chart and false positive. So things like this is, I would call a false positive. Usually the ADCs are much higher, over 1,000, compared to LMS, which are low, the average is under 800. And you can see other sarcomas that's in green. It's also pretty low, and together, they're low. But there's still some overlap, right? You can see there's still pretty significant overlap. So generally, if it's lower ADC, the better. But when they looked at the false positive, this is, I think, where I found it really helpful. That when they looked at the false positive, They found false positive, like comparing, like this, I would say is a false, my case is a false positive, to like true positive, right? The sarcomas, they find like, when you look at the uh, irregular margins, and that's what I think Aarti was alluding to. Irregular margins was present in all sarcomas and 50% of the false positive. And actually, that was much better than the T2 intermediate signal. So there was a lot of overlap in the T2 intermediate signal. So 80% of the false positive, like this case, like had T2 intermediate signals compared to 90% of sarcoma. So that's not a good differentiator. And so T2 intermediate signal is sensitive, but is not specific. It doesn't have a high PPV, but using a combination of irregular margins and ADC was more specific for sarcoma. And I think that's what I haven't done in the past that this paper has really kind of clarified for me is I didn't really look at the margins in the past. I mean, I know we talk about lobulated or kind of smooth round circumscribed margin or irregular margins, and I didn't really incorporate that. But if I were to like on this case, this has smooth margins, right? Like it's a nice smooth kind of. I don't know about the homogeneity, but certainly smooth margin, and kind of would kind of more characteristic of a benign lesion compared to, a sarcoma. The other thing that that paper did was they looked at cost effectiveness, which is really powerful because, at the end of the day, it comes down to cost. And they found that doing MRIs is very cost effective. Actually, it's less than 10 grand per 1 year of life gained. And usually the threshold that is used to assess cost effectiveness is um, $50,000. So like, for example, they mentioned like cervical cancer screening protocol is like 10 grand to 25 grand per year life gained. And lung cancer screening from the National Lung Cancer Trial, the cost effectiveness analysis showed it was like $50,000 per life year gain. And relative to those accepted practice, like MR for fibrate, like it's only 10,000. So it's well below the acceptable threshold to characterize and potentially help morbidity mortality in patients with suspected LMS.
Awesome. I love the cost effectiveness part. There were a few other, well, a couple of things about that paper looks amazing. So they said like once they used this group approach, they got a very, very like 97 to 100% specificity and sensitivity, I think I saw. But two other factors that they mentioned were hemorrhage and necrosis. And that's sort of what I was talking about with the post-contrast homogeneity. Like if there's necrosis, you wouldn't see that homogeneous appearance. So anyway, we have to check out that paper. Okay, Anu, do you want to go?
Sure. So this was a female patient in her 40s. So she has CKD. So this was like 13 years back or something. So she has this multiple cystic lesions. This is one of the cysts that I'm showing of interest. So between that scan and this one was like 6 months interval, and it started developing like a thick wall and some soft tissue component. So they went and resected it. It came as clear cell papillary RCC. And then she was on the follow-up. She underwent nephrectomy, and many years later, like I think it's about 9 years later, she had bilateral nephrectomy. She was on peritoneal dialysis. So this is all that we saw. She had serial MRIs. I'm just showing the one that was most concerning because she started developing like 1, 2 cysts in the surgical bed, and then it became more. And I'm like just scrolling through to show like this is her nephrectomy site. She had some similar cysts there. She had some along her surgical bed, and it's like along the course, like retroperitoneum. One of the cysts were like resected. This I showed in one of the prior scans, and for those who didn't see this case, I didn't have the pathology at that point. So they resected one of the cysts and came back as metastatic RCC. So I'm assuming like because the primary RCC was very predominantly cystic, the metastases came back as cystic RCCs too. They're not doing anything because it's so disseminated. They're just keeping her on chemotherapy for now. But it's a nice case to show how like along this site of surgery and retroperitoneum, she has its cystic metastases.
What was the histopathology again? Did you say papillary?
Clear cell. Sorry, let me get back 1 second. I'll give you the final one.
So it was
Well,
clear.
no, you said clear cell papillary, and I was actually going to ask you about that because that is a distinct subtype.
Yes.
And I think actually I found an AJR article about it. Clear cell papillary, a recent entity with distinct imaging patterns. And they basically said there's two distinct imaging patterns, including cystic and solid in almost equal proportion.
Oh, wow. So it's a clear cell papillary with cystic imaging appearance. Because, like, when we think about cystic, we think about Bosniak, right? Like cystic renal mass. And maybe we don't have MR, I guess, so we don't know what
She
percentage of
didn't have
it is
MR at that
solid.
point. Yeah.
Got
Like
it. And
because this was 6 months before, and then 6 months later, this was enlarging in size, and it was developing some thick rind of soft tissue. So they resected this one because they were suspicious about this one. It was only
got
6 months here
Yeah.
between this and this.
Which is so there's something happened, right? Like there's like
Growth and like
scary.
rapid
Because
growth with thick rind of tissue. You can see like there's some soft tissue inside here, like a nodular soft tissue. I don't know if I can.
but it's
Is it
not,
too
it's
big?
oh, it is contrast actually. Is it enhancing?
This is contrast.
Okay. Yeah.
Yeah, the wall was enhancing, the thick rind of soft tissue is enhancing, and then these nodules, if you're able to see, I don't know if it's projecting well. There was like small nodular
Yeah.
soft tissue inside it as well. So that was also enhancing.
I just thought about
This one was
like for
sorry.
cystic renal cell carcinomas, like we usually think about them as being indolent, right? Like they don't, like very, very rarely do they metastasize. Um, and it's usually the solid components, like the cystic part don't, but it's the bigger the solid components, the risk increases. And the metastasis post-op, it's all cystic. I mean, it's just a really bizarre presentation. And I think that's just because the subtype is completely different.
Yeah, I think so, because like it was like kind of like confusing why she had it. We were first like thinking maybe it's like a lymphangioma kind of a presentation. But then it was the cysts were resected and biopsy proven. So that was this case. I'll show.
I'm
I
skimming
think it'd be
this.
great for a case report. Go ahead.
I'm skimming this AJR article, and it is very interesting. This clear cell papillary variant. I can put it in the chat, but basically, it's frequently seen in patients that have renal failure. So it sounds like, like this patient who had the cystic disease of dialysis. And it's about 50-50 cystic and solid. And then they do say the cystic ones are generally indolent, just like other cystic renal neoplasms. So this is a super interesting presentation of Mets.
Yeah.
But the fact that they were growing over time, that's really weird. That'd be weird for lymphangioma. So I now,
They were increasing in number and size. Like,
yeah.
maybe I'll pull up one more MR or CT.
This actually reminds me of, and actually in this paper, they talk about von Hippel-Lindau related ones. And in von Hippel-Lindau, it's thought that most of the cysts are actually cystic neoplasms that are lined with tumor cells, but they look completely cystic. So I wonder if that's what these cysts are. Like they look super, 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 super cystic, but they're like lined with this thin layer of, tumor cells.
Probably. So I'm just showing like this CT 3 years before this MRI. You can see like the right renal bed had like probably like one, and then like this is 1 year after that. It's like increasing in number. You can see here, and then like it's more increasing more in number and also size.
Such a weird distribution too.
Yeah.
Cool.
Okay.
This patient presented with abdominal pain. This is the first study that we have. I do have surgical pathology.
It looks like a phlegmon abscess or whatever, but I noticed a couple of things. There's some big there's a really thickened like TI. There's some like really big lymph nodes. The lymph nodes are a little concerning to me.
So here's the
Like, are
lymph
those
nodes. Good.
reactive or is it
And then the TI
malignancy?
is right here. There's the
Yeah, there's
ileocecal
another
valve
stretch of ileum that's like really thick. But the
right
other
here.
thing, yeah. And then was there a tubular thing like a Meckel's? Like,
Yeah, I was wondering if it's Meckel's. Like, where's the appendix?
Okay, here's the oves. Let me see. So here's, we said ileocecal valve and appendix. Is it maybe this? I don't know. Maybe this little thing right
scroll
there.
through the bowel loops again.
Could it be this little thing right there? Okay, bowel loops. Scroll through the bowel loops. Okay. Do you want the sagittal?
No, I don't like sagittal for bowel. It confuses me.
I love the sagittals.
Oh.
Um,
Yeah.
and coronals.
No history of Crohn's, obviously. Or you would have told us. Or
Is it perforated Meckel's?
And where do you see the Meckel? Like what made you say that?
Like we see the
right
TI.
there, right there, right there. That thick soft tissue. Yeah, right there. That thing.
Yes, so this was that. It was that exactly. It was exactly Meckel's, and that you guys are amazing. And Crohn, like IBD Crohn's was raised. The patient, said they so anyways, yes, this was a perforated Meckel's on surgery. It was incidental. Just a couple things about Meckel's. 60% contain heterotopic tissue, and most of it is gastric mucosa. And because of the gastric mucosa, there's complications that can arise from it, like bleeding. You can get obstruction and very rarely perforation. And we only see that in about like 5% of patients. And there's the rule of twos, right? But the rule of twos actually isn't based on good data. But the rule of twos is usually 2 inches long, 2 feet from the ileocecal valve, 2% of the population, and usually in young people like less than 2 years old. Meckel's scan is very, very good. So it's 100% sensitive and specific for Meckel's diverticulum that contains gastric mucosa. So like we said, only 60% contain gastric mucosa. So that means there's going to be a lot of false negative, right? Because if it's not gastric mucosa, Meckel's scan is going to be negative, and cannot exclude actual non-gastric containing mucosa. And I learned that the reason technetium, so what they use is a 99M technetium pertechnetate, and that it works like a halide anion, like chloride and iodide, and gastric mucosa secretes chloride, right? Hydrochloric acid, that helps with digestion. And so the gastric mucosa, they accumulate the pertechnetate and then they secrete that into the intestines, and that's why it lights up on the pertechnetate scan. Again, only if it has gastric mucosa. So I'm going to share the surgical image with you, which I think is really neat. 1 second.
I was gonna ask, like, did this one this one looks like it perforated, but sometimes they
Yes.
have pancreatic mucosa, so like sometimes they get pancreatitis too.
This one perforated, yes. So this is the surgical specimen for that patient. And there's that phlegmon, and there's I think this is
Wow.
the area that's like where the Meckel's was coming out. So
Very cool.
So this was a patient in the 70s, 70s. So patient had a prostate MRI, and then he had a prostate cancer, so metastatic workup, and they found this. So differentials and what else it could be.
that doesn't look good.
I feel like it looks benign. But the
Like a
fact that it has
pacoma.
those big vessels in it, I'm thinking angiomyolipoma.
Can
Like
you
it
see it
looks,
like coming out of the like does it arise from the renal
yeah, like is
cortex?
there a notch sign?
Yeah, like an angular margin sign.
Mhm.
Because the other thing, I mean, it's got like fat. So like in my mind, I was thinking about liposarcoma. Uh, but it shouldn't be. It should be separate from the renal parenchyma.
Yeah, and the vessels were coursing through this. It was a very rare case, so I'll just give the diagnosis. They went in like for biopsy of this lesion because all these differentials were raised, like AML, like liposarcoma involving the renal hilum. They biopsied and came back as hibernoma.
Oh my
So
gosh.
hibernoma
Oh,
defect. Yeah, so it was like very rare. Like I've never heard of it. So I was like, then I went and read literature. So it was just hibernoma arising from this brown fat reactivation. So for imaging wise, like the differentials are like lipomas, liposarcomas, and AMLs. But for imaging wise, like for us to kind of raise the possibilities, they're benign looking. They will have an density on CT between the fat and the skeletal muscle. The density is not always fat, but it'll be like somewhere between the fat and the skeletal muscle, well differentiated, and they do enhance. And on MRI, like they'll have a T1 and T2 hypointense signal. They'll not have a fat signal, but T2 hypointense signal, and they will enhance. So that's the finding. They will
Anu,
not have any
Anu,
infiltrative feature.
tell it to us straight. Are you ever going to bring up hibernoma in your differential in the future?
No, no. But I thought like it was good to know. Like always, like especially when a patient is having a malignancy of this age, like we're going to have all the malignancies in the differential. But I thought it's good to know that something like this also exists.
It's like when Victoria shows us the case of liver mass that enhances washout, and it's like neuroendocrine tumor.
Yeah, you can.
Although we've seen it
Yeah.
so often now that like now I want to put it in all my differential with those
Yeah,
imaging
this
findings.
actually this is a really good example of like we started going down the AML versus liposarc path, but to be honest, it didn't really look like either. Like it didn't have the notch sign, and it
Mhm.
wasn't like pushing the kidney from behind. Although you could get
Yeah.
you can get a liposarcoma anywhere, but it to me
Mhm.
yeah, it didn't look like that. So I guess like I'm not entirely surprised it's a hibernoma, but I'm never bring it up. So, I don't know.
Yeah, never going to like include it, but like at least to know like it's not necessarily arising from the renal sinus fat, it's like perirenal fat. So
Yeah,
that's
I
interesting to
see.
like just look at it.
The other one I was thinking was extramedullary hematopoiesis, which can have fat.
Mhm. True.
Okay, so focus on the gallbladder here. I'll show you the coronal. This was like an outside with some limited images, but
Got an
so this
interesting.
is the gallbladder fundus and then the gallbladder and then the proximal portion of the gallbladder. So there's like, it's almost like there's two different kinds of gallbladder and then something at the fundus.
I'm gonna say segmental adenomyomatosis as well as
Yeah.
fundal
Yeah, so
adenomyomatosis.
that's what I would have said here. Like that, this is classic fundal gallbladder adenomyomatosis with these cystic spaces, which are like
Yep.
the cholesterol and glands and the Rokitansky-Aschoff sinuses. And then maybe even there's segmental
Yep.
hourglass gallbladder where like a ring of adenomyomatosis here that's causing two different channels with like stasis of bile in the fundus of the gallbladder.
I mean, could this also be like a congenital multiseptate gallbladder? I've seen that rarely, but seen reports of it at least.
Great thought. And I have seen a couple of those, but I would say that's much more rare. And usually those have septations crossing the entire gallbladder. So like this kind of bubbly cystic stuff at the fundus, I would say is more compatible with adenomyomatosis, but I do love the thought. And actually these two chambers, sometimes people bring up duplicated gallbladder, but it's much more commonly to just be an hourglass gallbladder with a ring of adenomyomatosis in the middle. That's kind of constricting it. Okay, 7 months goes by. Patient comes back, and this is what their gallbladder looks like now.
Ugh.
So we still got those cystic spaces, but now we've got this like thickened T2 hyperintensity.
Evil gray.
Yeah, evil gray, but I will show you a couple more. Okay, this is what it looks like post contrast. It almost looks like cystic spaces in the wall. And there was actually like hyperemia in the liver adjacent to the gallbladder.
And there were enhancing nodules in the wall too.
Yeah, there's like cystic spaces, enhancing nodules. It doesn't look like a classic gallbladder cancer. And I will tell you the final path was not gallbladder cancer. I'll show you. Oh, this is the true FISP. So you can see that, that was the adenomyomatosis, but even where the wall is kind of thick, there's all these other weird cystic spaces now. It's not gallbladder cancer. Anything else come to mind?
That content perf.
Great thought. It was not that. Lumen is pretty but like contained perf was great thought. Anyway, this went to resection, and this came back Xanthogranulomatous cholecysititis on a background of florid adenomyomatosis.
Wow.
So it was both, and it was really and we brought that up preoperatively. But what sort of
Wow.
told us that it might be that is that 6 months ago it just looked like adenomyomatosis. 6 months later, it looks, kind of more cystic, more inflamed, more thickened, blah, blah, blah. So,
Wait, you guys called it xanthogranulomatous cholecystitis pre-op?
yep.
Wow, superstars.
Let me see. I'm just gonna look at I can't show you the report, or I can't, I don't want to, although I would give kudos to I don't know what's appropriate in the interwebs, but yes, worsening gallbladder wall thickening with mucosal hypertrophy of the gallbladder with concretions within the gallbladder wall and enhancement of the liver parenchyma adjacent. Constellation is suspicious for xanthogranulomatous cholecystitis versus adenomyomatosis with superinfection, which is basically
Wow.
what it is. Yeah. Yeah. Cool.
Diagnosis of the year.
That's great.
This is a patient who had pancreatic cancer, Whipple, and I'm showing you a surveillance imaging, not for oncologic findings, but for kind of complications that we can see from Roux-en-Y. So here is the stomach.
I see a lot of thickening at the gastro-J with maybe an
Yeah.
ulcer. Is there like a marginal ulcer right there?
Here's the coronal.
Ooh, looks really thick.
Yeah, so here's the G, and there's the J, and there's the GJ, anastomosis.
Oh, it's an
I'm sorry.
anastomosis. I thought it was a fistula. DJ.
Oh yeah, it is like a candy cane anastomosis. And yes, there's a marginal ulcer right there. So there's a lot of hyperemia, and there's this ulcer here with surrounding thickening. And yes, this was I thought a really great pickup on CT of a marginal ulcer, which can be a complication of GJs. So a couple things. They can present with bleeding, sometimes nausea and vomiting, and we usually see this in the early post-op period. And they get these ulcers because of chronic acid exposure from the stomach. And typically, most of these can be managed with PPIs, but if they're refractory to medical therapy, then sometimes they have to do revision to address these marginal ulcers, and how we see them at the GJ anastomosis, and it's called marginal ulcer because it's at that margin of the anastomosis.
Nice. I feel like people often don't look at the GJ. So like really good reminder. We focus so much on the panc bed, like, oh, is there a new pancreatic ductal dilation and all that stuff, but good reminder to look also closely at the GJ. Anu?
This was a female in her 30s presenting to the ED with abdominal pain. So I'll just scroll down.
What's your HCG?
It was negative.
Oh.
Well, that weirdo thing in the left side looks almost outside of the uterus, like
like adnexal.
Is it ovarian or is it
Yeah.
potentially from the uterus?
Looks like a
What's
tourist ovary.
adnexal?
It's a left adnexal.
Yeah. Cystic and solid bilobed lesion.
And then there was all
Oh yeah, and like peritoneal carcinomatosis.
Yeah, that's what initially it was proposed. They said they proposed like there's a large left adnexal complex cystic mass, like peritoneal probable carcinomatosis with all this fluid. It turned out to be
Why can't it be tourist? Oh, go ahead.
Exactly. Yeah, it was a torsed left ovary with the fibroma, ovarian fibroma. And this was all edema in the ovary, and this was like fluid and reactive
Expanding.
inflammatory findings in the mesentery. Yeah. So how a large ovarian fibroma can cause torsion.
I get tricked by torsion
And
all
like
the
all her
time.
other markers were.
Wait, show me that
Yeah, I think this
peritoneal stuff
picture
though. I was
was-
really definitely tricked by that because it looked. Yeah, I guess it just is fluid.
here.
Yeah, got it. And no
Yeah.
Meek syndrome, it looks
Yeah.
like. So no pleural effusions and stuff.
No.
Although
Nothing.
maybe that perihepatic fluid, maybe that is Meek syndrome.
Yeah, very trace. But no pleural effusion, other things. But this was all like from like torsion, I guess. She had like a large ovarian fibroma and she had like a giant cyst. And overall, I think it measured like 7 centimeters or something. So it was all edema in the ovarian stroma and then like torsion. There was no malignancy at all. They tested the fallopian tube, the ovary, the ascitic fluid, everything was negative. And she had a giant fibroid too.
Isn't it amazing that big cystic thing though was like probably one of the cysts in the ovary too?
Yes.
Wow. Okay. So this is just kind of an interesting one. So my friend, my colleague was reading this exam, my friend and colleague, and just said incidentally noted as artifact here, coursing in the expected location of the IVC cannot evaluate the IVC. Going all the way up.
Any others? Like, is there a CT or any other imaging finding anywhere?
Well,
Like,
it was really mysterious and
it's like a cannula or something, because
Like
it
an
goes from the
ECMO.
femoral all the way to the heart, like an ECMO. Yeah.
exactly, right? But this is an outpatient. This is like a walkie-talkie
Oh,
outpatient. Like no, they're not on ECMO.
Not on like a dialysis catheter, like femoral dialysis catheter.
Maybe. We didn't go deeper into it. We just said there's an artifact. And
oh,
then the team was like, or whatever, the ordering clinician for this outpatient was like, why is there an artifact throughout the entire IVC? And so they ordered a CT scan, but and I'll show you the CT. Okay. So here is the
retained catheter.
yeah. Okay. So it goes all the way from here,
Yeah.
all the way up here. Okay. So they said, describe this thing. And then they got a chest and it goes all the way up into the neck. And then when we looked back, we could see it on multiple prior abdominal
Oh,
radiographs.
oh my.
Okay. So it's multiple prior radiographs. But, when you're reading an abdominal radiograph and you're like, it's an inpatient, whatever, like they've got lines and tubes everywhere, right? So we went back further and further, and it was there for several years. And so anyway, it turns out this was a retained catheter from an intraoperative when they got their renal transplant. I don't know what catheter, I don't exactly know what wire it was, but the wire was left in. So they then when we identified it on the MRI, creating this artifact, and then we saw it on the CT, they consulted IR to remove it. I'm just trying to find the IR lasso image. But actually one small part in the pelvis retained, and I think it was just like adhered to the wall and then ended up breaking off. So they decided to just leave that there rather than, more aggressively trying to take it out. So yeah, it was
Wow.
a retained catheter.
Wow.
Okay, and then oh yeah, wait, okay. This is the lasso. So IR went in and, got a hold on it and then pulled it out. So
That's a
Okay.
long wire.
Yeah. Okay, who was it? Cameron or Alicia that said they had one?
Oh yeah, that was me, Cameron.
Okay, awesome.
So this is a patient who had a history of squamous cell carcinoma of the parotid gland. On a PET CT for staging, had a big right adrenal mass. He's got a little bit of uptake in there, but it's not really greater than liver, really kind of similar to blood pool overall. So they got an MRI to look at this a little bit further. I'm just going to switch screens here. All right, can you see the new screen now?
Yep.
Okay, so MR, mostly very kind of T2 hyperintense, kind of similar to fat there on the T2 images.
Do you have fast sat sequences?
Let me see on the T2 fat sat. Let me pull it up without showing any thing there. And you can see it's still very bright though, so it's
Ooh.
not fat. And then when we get to the post-con, you can see there's a little bit of nodular enhancement here. And it looks like gradually increasing enhancement as we get to the more delayed phases. We got our
Hemangioma.
portal venous. And that's exactly what I thought. I was really hoping this was going to be a hemangioma. Did not come back as a hemangioma, which was shocking. We have
Pheo.
even a CT here, which I will show. Didn't come back as a pheo either. So you can see on CT, just to prove it, we got they asked for an adrenal protocol for whatever reason. I don't really know why, but you can see that nodular discontinuous enhancement looks more impressive here, and then
What's the
kind of
density on the
gradually fills
pre-con?
in. On the pre-con,
She wants to know if it's more than
46.
43. It's more than 43.
It is. Look,
It's 46. So
that's suspicious.
yeah. So anyway, this is just super weird. It came back as hematoma, and whatever it was had completely infarcted, and this was just hematoma, and it was bleeding into the hematoma.
Wow. Do you have the T1?
Yeah, let's see. The pre-T1 right here. So I don't know.
No, we
It was
can't
kind of
see it.
weird.
We can't see the pre-T one.
Oh, hold on. Let me see. I put it on the wrong screen. It is right here.
Huh.
Oh, wow.
Yeah.
Yeah.
Amazing. Couple of things.
So it must be a really
One,
old hematoma, right?
yeah, so actually I had a case just like this, and it had bleeding into it and all the stuff, and the path came back ancient hematoma.
I love it.
I
That's
learned,
awesome.
no, literally I learned about this entity, which is that you can get a hematoma that is like really old, but that has like chronic bleeding within it because it like creates these friable vessels that bleed over time.
But in
Um,
this case, the T2 was bright, right? If it's a very chronic hematoma, T2 should be dark as well. Shouldn't
Oh, yeah, it was super bright.
yeah,
Mm-hmm.
but then if it's more acute, the T1 should be bright. I don't know. I think it's a chronic hematoma with chronic bleeding.
Yeah. The path said specifically that there are no viable cells within the entire lesion. It was just
I will,
hematoma.
as a caveat, I had a very similar case and it was a lung cancer met. We just kept calling it a bleeding hematoma that was increasing in size.
Hmm.
And it
Oh,
came back lung cancer met. So
oh.
I'm a little cautious these days, but
Wait, so why was there FDG avidity? It
probably
must have
for
I
been
assume
something
it's just blood.
viable.
It was like similar to blood pool for the FDG avidity. It was,
Oh, filling with
if I,
blood.
let me put it back on that screen. But if you compare it to the aorta, it's kind of similar heterogeneity. You see the same level of heterogeneity in the blood pool in the aorta. So I think it's just FDG within the blood. It's bleeding into the hematoma.
So then that's why we see it fill in on the venous. Like it's just slow interstitial blood.
Yeah.
Interesting. What a great case.
did you I have a question. Why did it go to resection? If, for example, like say you said hemangioma, and then presumably you did the whole pheo workup and that was negative.
I think it was mainly because the patient had the history of squamous cell carcinoma, and they do have
Oh, got
mets
it.
in their neck, and so they were wanting to be certain that it's not metastasis or something else worrisome.
Yeah, that makes sense. Cool. Well, great cases, guys. So glad to have you back, Anu, and welcome to the newbies. And we'll see you next time.
Thank
Thanks
you.
all.
Thank you.
Thank you.